turn to introduce you all. So welcome to the Newborn Care Seminars. And we've got Richard Polin, Professor Polin from New York, very late at night. Kurt will give you all his bio, but just a bit of background and housekeeping notices. Our talks, if the speakers allow, will be posted on WhatsApp and WeChat. Past talks are available from this Dropbox, and our Physician College and College of Nursing will accept self-declaration of attendance for this talk for 1 hour of CPD points. At the end, I'll flash up a QR code for you to record if you want to have proof of evidence of attendance. So email us on this very clunky email if you want to join our groups or be added to the email list. And just make sure you're muted at all times. If you have a burning question, raise your hand and Kurt will moderate the session and allow you to talk if you want. We'll try to leave 10 to 15 minutes at the end for a Q&A. But in the meantime, while Richard's speaking, just type your questions on the chat box and we'll try to get to them at the end. So without further ado, over to you, Kurt. And thank you so much, Professor Polin, for staying up late to talk to us.
Yeah, thanks everybody. Welcome everybody. I think Professor Polin needs barely any introduction. From the University of Columbia, New York. I think we all read his books. He's been practicing pediatrics and neonatology before many of us were even in medicine, but certainly in an era before surfactant and antenatal steroids. I must have experienced such interesting cases, but also the progress into neonatology, which we can all read from his excellent sort of reference manuals and books and key papers. And it's a great honor to me to introduce you.
Recording in progress.
Richard, and to talk to us about antibiotic stewardship. The floor is yours.
All right, let me find this.
Yeah, oh, good, visible, thank you.
All right, great. It's fun to be with you, even a late night for me, early morning for you. I'm going to be talking about a topic that is of great interest to me, and it's really a worldwide problem. That's the overuse of antibiotics. As you know, children and adults are frequently given antibiotics for trivial infections or maybe a prolonged fever. But those of us who care for babies in the NICU really have a problem, because at least 90% of our ELBW babies weighing less than 1,000 grams receive antibiotics, mostly for non-infectious diseases. So I have two aims or two objectives. Let me see if I can make this go. One is to review some of the adverse effects of inappropriate and prolonged antibiotic use in the NICU. And secondly, probably more important, is to provide a rationale for antibiotic stewardship in the preterm infant. So this is my hospital in New York City. We're at the northern end of Manhattan. It's really 3 different age buildings which comprise the pediatric department, but the newer building was built about 13 or 14 years ago. It's called Morgan Stanley Children's Hospital. It's not a bank. They really gave us the money to build this hospital, and we're located on the 7th floor. At least the main NICU is located on the 7th floor, but just 2 floors above, we're one of the only centers in the US that actually has a cardiac NICU that's run by neonatologists. So we're known for many things in the United States, but one of those things is we have the best looking doctors and nurses in maybe the world, but at least in the United States. I'm sorry this has to be a Zoom call. I hope some of you are getting a smile looking at Donald Trump. And I can say now, I hope he doesn't become the next president of the United States, but time will tell. So when a baby has a suspicion of sepsis, or you hear that a baby may have risk factors for sepsis, you have a few options. If you have a very low risk notion that the baby may be infected, you may just leave the baby with the mother and peek in maybe a couple of times. On the other hand, if you're really concerned about the baby, you want to peek in more frequently to examine the baby. Some of you may recognize a very famous Columbia alumnus, Virginia Apgar, famed for the Apgar score. Or if you're really concerned, you put an IV in the baby, you take a blood culture, maybe get some lab tests, and start antibiotics. When I was a fellow, seems like a long time ago when I say it, it was the 1970s, we thought sepsis was pretty easy. I'd call it a no-brainer. When a baby had suspicion of sepsis, either because of risk factors or clinical signs, we did do or draw a blood culture and began antibiotics with penicillin and kanamycin. Sounds pretty primitive compared to now our current antibiotics, but most babies got better, probably because most babies never actually had an infectious disease. And sure, we knew about aminoglycoside toxicity, including ototoxicity and nephrotoxicity. But back in the 70s, we never dreamed that certain antibiotics, especially third-generation cephalosporins, may be associated with an increased mortality in the newborn infant. And in the past, so maybe 10, maybe 15 years, there's a new concept, dysbiosis, which is a change in the flora of the baby. Well, I'll talk about this later in my lecture, but that kind of dysbiosis has been associated with long-term complications of late onset sepsis, necrotizing enterocolitis, and bronchopulmonary dysplasia. But there are some things we should have realized back in the 70s that we didn't. One is that putting a baby in the NICU, especially a baby who just has risk factors but no other signs, separates mothers and babies. It interferes with bonding and certainly delays breastfeeding. It exposes the baby to unnecessary procedures, and the risk of IV infiltration is not trivial. Probably every 3 or 4 months, we have an IV infiltrate in my NICU that requires the plastic surgeons to repair. And certainly it prolongs hospitalizations and increases expenses by virtue of having the baby in the NICU. And these are data now about 6 or 7 years old now from Eleanor Malloy, and she wrote an article trying to estimate the cost in the United States of admitting every baby exposed to chorioamnionitis in the mother for 48 hours and look at what it would cost to prevent one death. And the estimate is $10 million. Obviously, these are numbers that are several years old now. If you think of the worldwide numbers, the cost of admitting every baby exposed to chorioamnionitis is considerable. Let me start with some numbers, and these are really numbers that refer to late preterm and term babies. First of all, sepsis is not very common. The incidence in the US in general is about 0.5 to 1 per 1,000 live births. In well-appearing late preterm and term babies, the incidence of sepsis is very low. It's about 1 in 25,000. And that means no matter what the risk factors in a healthy appearing late preterm or term baby, those babies need just observation and don't need a culture or antibiotics. Sepsis workups, as you know, are far more common than babies with proven sepsis, and most of the workups are for non-infectious diseases that result in clinical signs and symptoms. In our premature population, the numbers are quite different. The incidence of sepsis is at least 20 times higher than our late preterm and term babies, anywhere from 9 to 11 per 1,000 live births. 75% of deaths from sepsis occur in the VLBW population, less than 1,500 grams. I've already mentioned just about every very low birth weight infant receives broad spectrum antibiotics for possible sepsis, the so-called rule-out sepsis, most of them being unaffected. And prolonged antibiotic therapy, which is an important variable, greater than 5 days, is used in more than 1/3 of our ELBW babies. And it's that prolonged antibiotic therapy that is associated with the long-term complications I've already mentioned. So the question is, how to identify the infant with clinical signs or risk factors who's actually infected and avoid treating others? The concept we would use in the United States is like finding the needle in the haystack, the baby who's actually infected. And the corollary to that is, can we safely decrease antibiotic exposure in newborn infants at lower risk for sepsis? And for me, there are two main opportunities to decrease antibiotic exposure. One are healthy appearing late preterm term infants, more than 35 weeks gestation with risk factors for infection. That includes the risk factor of chorioamnionitis or intra-amniotic infection. That's a very low risk group who probably does not need antibiotics. And the other is preterm infants with no risk factors for infection, those born by elective cesarean section for maternal indications with either artificial rupture of membranes or rupture of membranes at delivery. And frequently those babies are born to women with hypertension. We all like evidence in everything we do in the NICU. There's a very famous phrase by not a physician, by this individual. His name was Carl Sagan, died a number of years ago. And he is an astrophysicist, and he said, absence of evidence is not evidence of absence. And he was talking about life on other planets. But it really applies to how we practice in the NICU. And my not so eloquent take on evidence is not all it's cracked up to be. So we have to ask ourselves, what is neonatal sepsis? I'm sure some of you are saying, well, that's pretty easy. It's a positive blood or CSF culture. And that's how the Centers for Disease Control defines sepsis. But there are other entities I need you to think about. For example, what about transient neonatal bacteremia? Babies that have a positive blood culture and the baby clears it and then is well after that. And I think that's probably more common than we appreciate. And then again, how do we interpret blood cultures? I'm talking about early onset sepsis now for coagulase negative staphylococci. Sure, those are important pathogens for late onset sepsis, but when we get it for early onset sepsis, I don't usually think about it as a pathogen, more a contaminant. And how about polymicrobial sepsis? And then there's a large category of babies that have signs of sepsis. Maybe they had multi-organ dysfunction. They have laboratory evidence of systemic inflammation. For example, an elevated C-reactive protein or procalcitonin, but they have a negative blood culture. That's called clinical sepsis, but is it truly sepsis? Some of those babies probably do have sepsis or a positive blood culture. Perhaps it was missed with the blood culture when the blood culture was taken. But the majority of those babies probably have non-infectious diseases. And the question that's not been answered clearly yet is culture negative sepsis associated with adverse neurodevelopment. Only one paper from about 2 years ago where there was a suggestion of adverse neurodevelopment with culture negative sepsis, but there is very limited data. So this always surprises me. These are data from the pediatrics group. It's a group whose name ends in IX all over the United States. And it's a large database of 608,000 blood cultures for early onset sepsis. Only 2% were positive. So the majority of blood cultures are going to be negative in babies that we take blood. So culture negative sepsis is when an infant's evaluated for sepsis, has symptoms or lab values that are concerning for infection, but whose bacterial cultures are sterile. The incidence of culture negative sepsis exceeds that of proven sepsis by 16-fold in my country, the United States. And if you look at low to middle income countries, by at least 50-fold, where culture negative sepsis is way more common. What are the causes? Well, the top two on this list, non-infectious sepsis-like syndrome or physiologic instability due to prematurity, are probably the most common causes. Those are non-infectious diseases as the baby makes the transition to postnatal life. Pre-treat with antibiotics, I'm going to show you data that says that's probably not very important. In an older baby, focal infection without bacteremia may be important. And that's why and therefore focal infection, nephrotitis colitis, osteomyelitis or UTI can cause clinical signs without bacteremia. And then there may be a viral fungal pathogen or anaerobic sepsis or a fastidious organism that's not easy to culture. And clearly there are unculturable pathogens only detectable by molecular methods. And we're actually starting a study in our group to identify those pathogens. And lastly, is the amount of blood that somebody gets for culture is insufficient. I'll show you some data on that in just a moment. So does treatment of culture negative sepsis have serious consequences? This is a study that was published about a week ago. And I just saw it in pediatrics, one of our major pediatric journal. And it's from China. It's a secondary analysis of a prospective cluster randomized trial. And you can see the number is quite high, 21,540. The babies were a little more mature than we're used to caring for, at about 31 weeks. And there were relatively few babies in the study. There were less than 28 weeks. And I think there were 15 NICUs in China in the study, and every NICU had its own site guidelines regarding early antibiotic use. There were no national guidelines. And the outcome was, the primary outcome was a composite outcome of death or any one of the morbidity you see on the screen: bronchopulmonary dysplasia, retinopathy of prematurity, periventricular leukomalacia, necrotizing enterocolitis, and late onset sepsis. Any infant with any infection-related morbidity in infection in the first 7 days of life were excluded. So these were not babies with early onset sepsis. So here's the outcome for this study. Approximately 18,000 received early antibiotics for a median duration of 6 days, which is quite long. The rest did not receive antibiotics. 23% of the infants developed the composite primary outcome with early antibiotic use, with only 16.4% in infants without early antibiotic use. Early use of antibiotics was not associated with increased mortality or any individual morbidity except BPD, bronchopulmonary dysplasia. The effect of early antibiotic therapy on BPD, as it turns out, was only for non-critical infants. Not critical infants for those who were ventilated or received pressors. So the association, I'll call it association, between antibiotic treatment and BPD was only for non-critical babies. Prolonged treatment, more than 5 to 7 days, and broad spectrum antibiotics had a greater effect on the risk of BPD. And interestingly, early antibiotic use was associated with a lower risk of necrotizing enterocolitis. And we can try to discuss that during the question and answers. Well, I mentioned the volume of blood is critically important, because if you don't get the right amount of blood, it may lead to culture negative sepsis. And this is I think, a neat in vitro study done by a pediatric resident who became a neonatologist, Sri Lanka, and a number of years ago. It's an in vitro study in which he inoculated blood specimens with group Streptococcus coli at 4 colony-form units per ml or 1 colony-form unit per ml, and then took out in this in vitro study a half, 1 or 2 mLs, and asked the question, how often can we recover at least 1 colony-forming unit? So if the original bacteremia was 4 colony-forming units per ml, you take out half an ml, you have an 80% chance of detecting that bacteria. On the other hand, 20% chance you'll miss it. An ml, 92% chance. 2 mLs, 99% chance. And if it's a very low colony count bacteremia, and you take out only a half an ml, you only detect that 1 colony-form unit about a third of the time. 1 ml, 60%. 2 mLs about 82% of the time, with very low colony count bacteremia. And my recommendation, and sometimes it's hard to do, is we try to send at least 1 ml for culture. Now here's my algorithm for managing early onset culture negative sepsis. So if you have suspected sepsis with a negative blood culture, and you've taken an ml, if the baby is clinically improving, shown over here on the right side, you stop antibiotics, and our rollouts are only 36 hours in our NICU. I think most centers in the US are moving to 36 hours. However, if the baby's sick, there's no clinical improvement. If they're critically ill, you may broaden the antibiotic coverage, add different antibiotics, And I recommend a lumbar puncture. Remember that about 30% of babies with meningitis have a negative blood culture. If the LP is negative, the baby's been seriously ill. We would treat that baby for about 5 to 7 days. If the lumbar puncture is positive, depending on the pathogen, you treat for 14 to 21 days. But remember, in late onset sepsis, you have to think of other causes such as UTI, NEC, and osteomyelitis. Well, these are the culprits we use in the United States. I'm sure some of you do use these, ampicillin, gentamicin. Others may use different combinations of antibiotics. And this is a study of almost 900,000 babies, and just noting that ampicillin and gentamicin were the two most common drugs used in the NICU. This is what clinicians say about routine use of antibiotics. And none of these things are true. They say that routine usage of antibiotics in high-risk infants has decreased mortality and morbidity. Not true at all. There are few or no downsides to broad-spectrum antibiotics of any duration, and I've already alluded to say that's not true. And thirdly, they say if it's good for children and adults, it must be good for babies. We know that's never the case. And lastly, they may say, well, someone told me that. Well, if the person looked like this, you got to think twice about listening to them. But if the person looked like this, you want to say, well, this is a pretty smart person. And this is, if you don't know, this is William Silverman, Bill Silverman. He's the father, I consider him the father of evidence-based neonatology in the world. This is what he said in 1949. He said, the diagnosis of septicemia should be suspected in every newborn who is obscurely ill. It is clear that a complete history, physical exam, and laboratory data should give an early diagnosis. And then he said, it is justifiable on the basis of reasonable suspicion alone to begin vigorous antibiotic therapy, sulfadiazine, penicillin, streptomycin, while awaiting culture confirmation. And I highlighted sulfadiazine because it's a sulfa compound. As you know, sulfa displaces bilirubin from albumin. And that recommendation, which was followed by many centers, at least in the US, led to an outbreak or an increase in the number of cases of kernicterus. And it was Bill Silverman that later proved that sulfa compounds displace bilirubin from albumin. So here's sort of the scientific answer why antibiotics are so pervasive. First of all, it's hard to identify the baby with sepsis from non-infectious conditions, since the signs are very non-specific. Clinicians have assumed that commonly used antibiotics have few risks and serious complications. I've already mentioned infiltrates. We don't have a good handle on renal toxicity, but there is a paper out there saying renal toxicity may be as high as 30%. I'm going to speak about the microbiome, but it's sort of invisible to everybody, so people don't worry about it. And in our center, people don't think about costs, but it is a major consideration, and healthcare costs in the United States are skyrocketing. And as you know, once starting antibiotics, it's very hard to stop them. Especially is true if one of your laboratory tests, for example, the white blood count or C-reactive protein demonstrates an abnormality. It's very hard to stop antibiotics. But I can say now that I never treat babies solely for abnormal laboratory tests. So I don't care if the C-reactive protein is 100 billion and the baby looks well, I still stop antibiotics. So babies can get infected through 4 different pathways. 2 of them are really very uncommon and 2 a little more common. Oh, let me go backwards. Retrograde infection from the molars abdominal cavity, shown at the top of the slide over here, very uncommon. Infection introduced at the time of amniocentesis, also very uncommon. Then there are 2 that are more common. There are the transplacental infections, which are hematologous infections through the placenta with agents like a cytomegalic inclusion, virus, and toxoplasmosis or rubella. When we talk about early onset sepsis, we talk about organisms which go from the birth canal up into the amniotic cavity and then into the amniotic fluid. and the mother develops an intra-amniotic infection. That's sort of the new term for that's equivalent to chorioamnionitis, and the baby either inhales or swallows the infected amniotic fluid. So how important a risk factor is intra-amniotic infection or chorioamnionitis? Well, it depends on gestational age. If you're a late preterm baby born to a mother with chorio, the risk of infection is actually quite low. It's probably about 1%, maybe even a little bit less. If you're a preterm baby, though, and these are data from Barbara Stoll from the NICHD Neonatal Research Network, looking at babies 22 through 28 weeks gestation. And you can see the three outcomes here are histologic chorio, clinical chorio, and early onset sepsis. So at 23 weeks gestation, which used to be our lower limits of viability, now we have many survivors at 22 weeks. About a quarter of all women have clinical chorioamnionitis or intra-amniotic infection. And early onset sepsis is seen in lots of babies, about 4%. On the other hand, at 28 weeks, only about 14% of those mothers have clinical chorioamnionitis with a risk of sepsis of about 1%. And it's important to remember that intra-amniotic infection can be overt or subtle. We know that organisms can spread upwards into the amniotic cavity and that mother be completely asymptomatic until she develops preterm labor or preterm premature rupture of membranes. And we know from women who are having genetic amniocentesis that somewhere between 15 and 20% of those amniotic fluids, if cultured, will reveal a microorganism. That's not to say that she's infected, but clearly colonization of the amniotic cavity is more common and than we appreciate it, and clearly overt. So can we diagnose intra-amniotic infections with better precision? These are sort of the old criteria developed in the early 1990s by a maternal fetal medicine physician, Ron Gibbs. And he said, well, you have to have fever of 100.4 degrees Fahrenheit or 38 degrees centigrade, plus two of the things on this list: maternal fetal tachycardia, an elevated maternal white blood count, uterine tenderness, or foul-smelling amniotic fluid. But this definition is very problematic because every time a mother had a fever, the obstetrician would come to us and say, oh yeah, we're concerned about chorioamnionitis in this mother. So it was used too freely, and the diagnosis of chorioamnionitis was bandied about when the mother probably had another cause of the fever. In 2017, I led a workshop at the NIH, and then subsequent to that workshop, the American College of Obstetrics and Gynecology came up with new definitions and had a category of isolated maternal fever. The whole point of that was to try to pick out women who have fever but do not actually have an intra-amniotic infection. So isolated fever was a fever of 38 to 39. Suspected intra-amniotic infection is a fever greater than 39, or 38 to 39 plus an additional risk factor, such as a high maternal white count, purulent cervical drainage or fetal tachycardia, and then there's a confirmed intra-amniotic infection based on a positive test on amniotic fluid or placental histopathological evidence of placental inflammation. And they said, when intra-amniotic infection is suspected and confirmed, give that mother intrapart of antibiotics to try to treat that infection. But remember, there is a category of just isolated maternal fever. So, and it has led to a decrease in the number of babies born to women designated with chorioamnionitis. So what are the real goals of neonatal antibiotic stewardship? Some babies, as you know, need antibiotics. Some babies need lots of antibiotics. Antibiotic stewardship is not about giving less antibiotics. It's about giving the right antibiotic to the right babies for the right reasons and clearly at the right dose. So the question is, can we have antibiotic stewardship in a preterm baby? Well, it's pretty easy to identify risk factors for early onset sepsis in our preterm population. prolonged rupture membranes, PROM, intraamniotic infection, also called choreo, preterm premature rupture of membranes. The mode of delivery is important, race and gestational age. However, the independent contribution of any specific risk factor other than gestational age is difficult to quantify. That is why there's no such thing as a sepsis calculator for preterm babies, only for our late preterm and term babies, because these other risk factors cannot be quantified. In addition, in many cases, infection in preterm fetuses begins well before the onset of labor, and that is not as true for our term and late preterm babies. So this is an important study because it attempts to identify which preterm babies are at lowest risk for infection. It was a retrospective observational study of babies 22 through 28 weeks gestation to identify babies again at low risk for infection. And low risk infants were defined as delivery by cesarean section with membrane rupture at delivery and absence of intraamniotic infection or chorioamnionitis. And their study included babies from the Neonatal Research Network database. And when they applied the low risk criteria, just shy of 40% of babies met the low risk criteria. The incidence of sepsis in this group, remember these are preterm babies, was 0.5%. In the higher risk group, it was 2.5%, 5 times higher. Many infants in the low risk group were quite ill. Most received surfactant, were ventilated. Therefore, clinical signs are not helpful at all in identifying low risk infants. Low risk infants had a significantly lower combined risk of death or early onset sepsis. The number needed to treat preterm infants born to women with intraamniotic infection generally ranges from 6 to 40. However, in the lowest risk group, the number needed to treat is greater than 200. And this is what the Committee of Fetus and Newborn, which is what the American Academy of Pediatrics endorses for babies less than 34 and 6/7 weeks gestation, categorize the baby as lower risk or higher risk for infection. Low risk infants should have no laboratory evaluation or systemic therapy or blood culture. But they do say for infants that do not improve after initial stabilization or those that have severe systemic instability, the administration of systemic antibiotics may be reasonable. So there's an out if you're really concerned. And high risk infants, those that don't meet the low risk criteria, should have a blood culture and receive empirical antibiotics. I just want to mention this study that is ongoing now. It's called the NANO trial. NANO stands for NICU antibiotics and outcomes. And it's a trial, it's a randomized trial of giving preterm infants 23 to 28 weeks gestation, either placebo or ampicillin and gentamicin. The study has enrolled so far about 170 babies, but the outcome for this study is a combined outcome of late onset sepsis and necrotizing enterocolitis and mortality. And our hypothesis is the babies who receive antibiotics will have a higher composite outcome for those 3 indications. As I said, that study is now ongoing. So let me give you a case, and I can't look at responses, but I hope you're thinking about this case. This is a 1.5 kilogram infant, Kim Jae-yu, born at 30 weeks gestation, delivered vaginally with rupture of membranes for 15 hours, so it's a little prolonged. The mother had minimal fever or significant fever of 38 degrees centigrade. The infant was started on CPAP with 45% oxygen. The chest X-ray was compatible with RDS. At 36 hours, the blood culture was negative, and the infant's improving. However, the intern, called DT, wants to treat for 7 days, feeling the blood culture was invalidated because the mother received ampicillin and gentamicin. Here's baby Kim, and here's our intern. He never figured out where you should put the end of the stethoscope. So I can't look at hands, but how long would you treat this infant? And I've heard you say that our standard in the US, or at least in our hospital, most of the US is 36 hours, but other options are 5 to 7 days, as was done by the NICUs in China, regardless of laboratory testing. Or you might say 5 to 7 days only if my laboratory studies are abnormal. And the correct answer for me is 36 to 48 hours. This is a neat study because it looks at the time to positivity of blood cultures for illness and sepsis and examines whether intrapartum antibiotics really affect the time to positivity. This is a retrospective study, 70,000 babies in the first 72 hours of life. Most of the positive blood cultures were actually contaminants in the study, but the time to positivity was not affected by maternal antibiotics. Here's the overall population. You see, most blood cultures are positive, 94% by 36 hours. That's why if the baby's doing well, that's why we've chosen that time point to stop antibiotics. This curve on the left compares contaminants with true pathogens. I see true pathogens even go out a little bit quicker. And the graph on the right looks at the effect of intrapartum antibiotic prophylaxis. And there's absolutely no effect of giving maternal antibiotics on the time to positivity of blood cultures. And there's an interesting statement in this paper by Kuznowitz. He said the authors estimated that using 36 hours empiric antibiotic duration would have avoided over 3,500 doses of unnecessary antibiotics for the risk of interrupting ongoing therapy in one baby with bacteremia. That's why we have chosen, again, to use 36 hours as our standard, our NICU for empiric therapy. Now I'm going to address what are the unseen risks, and I'm going to specifically talk about the microbiome. And the microbiome in the newborn baby is influenced somewhat by the mother. Remember, the baby is swallowing amniotic fluid, so if there's organisms there, they'll swallow those organisms. Maternal lifestyles is an important variable. Does she live in a rural or urban environment? What's her diet like? And did she receive antibiotics prior to birth or during the birth process? And then there's a newborn baby influenced by the kind of birth, cesarean section or vaginal delivery. Did the baby receive maternal breast milk or a bottle? Was the baby exposed to antibiotics? And where in the hospital is the baby being nursed? Is it in a NICU or is it some other location in the hospital? And we know that antibiotics disturb the microbiome. And I've showed this picture a little earlier. And again, here are the 3 complications that have been associated with use of antibiotics and dysbiosis: bronchopulmonary dysplasia, necrotizing enterocolitis, and late onset sepsis. This is a study by Pammy and Joe New. It's really a meta-analysis looking at the kinds of bacteria isolated in babies who are developing necrotizing enterocolitis. So in the left part of the slide up here are control infants who did not develop necrotizing enterocolitis. On the right are infants who develop, or studies where the babies develop necrotizing enterocolitis. The blue color represents proteobacteria, or gram negatives. And it's pretty easy to see that in babies who are developing necrotizing enterocolitis, there's a greater predominance of proteobacteria than in the control infants. And in fact, these are data from Mike Cotton, by Matt Pizarro, showing that the number of days that you treat with antibiotics has a direct relationship with the odds ratio, shown the y-axis, for necrotizing enterocolitis. And the thought is it disturbs, it disturbs the microbiome and places the baby at risk for necrotizing enterocolitis. And here are very similar data looking at airway microbiome in full-term babies on the left, ELBW babies who never develop BPD, and ELBW babies develop BPD. And again, the blue color are gram negatives, showing that babies who develop BPD, or ELBW babies who develop BPD, have a much greater predominance of those proteobacteria or gram negative microorganisms. And then there are the long-term sequelae, which I'm not going to discuss today. Again, these are all association: asthma, diabetes, eczema, atopic dermatitis, childhood obesity, and bacterial resistance. This is an interesting, more recent study which tried to examine both intrapartum antibiotics and postnatal antibiotics. It's a prospective study investigating the microbiome of babies exposed to either intrapartum or postnatal antibiotics. And in the end, they had 4 groups: babies who were not exposed to either kind of antibiotic, babies who were exposed just to intrapartum, babies who were exposed just to postnatal antibiotics, or babies who were exposed, the YY, but to both intrapartum and postnatal antibiotics. And what they showed by looking at the microbiota is that Bacteroidetes, which includes the phylum Actinobacteria and the genus Bifidobacterium, is a probiotic. Anyway, that Bacteroidetes was increased in infants who were not exposed either to intrapartum antibiotics or postnatal antibiotics. And Actinobacteria are actually very important. They they have immunologic functions. It downregulates inflammation. They're important in the gut-brain axis. They produce the short-chain fatty acids, which nourish the intestine, and also help maintain the gut barrier permeability. And as you know, a decrease in permeability is probably one of the mechanisms for necrotizing enterocolitis. In addition, they showed that the infants treated with antibiotics, including just intrapartum antibiotics, had increased numbers of resistance genes. And when they looked 6 months later, the effect on the microbiome was still evident 6 months later. And they asked the question, does using probiotics influence these findings? The answer is no. And just one other study to show how treatment for early onset sepsis really has long-lasting effects on the newborn baby. The 2 sets of curves here, the first set of curves are full-term, vaginally delivered breastfed babies, of whom none of these babies got antibiotics. The second are preterm babies who received an evaluation for early onset sepsis. And you can see here, even 90 days later, just by looking at the colors, the effect on the pattern of bacteria is still present 90 days later, 3 months later. And by the way, that red color there are the proteobacteria. How about stewardship for late preterm and term babies? I'm only going to mention this very briefly, but we have the sepsis calculator, which is always combined with other observations. Or an alternative to the sepsis calculator is just to do very frequent observations of the baby, keep coming back every couple hours to make sure the baby's well. And some people have actually combined serum observations and, in addition, some screening laboratory studies. So how can we identify late preterm and term babies who need antibiotics? Here's our former president using his fingers to say how many risk factors are there. I'm not going to belabor the point, but the sepsis calculator uses a combination of risk factors. And the risk factors in the sepsis calculator, you can go to it by Googling sepsis calculator, are shown over here. They include gestational age in weeks and days, duration of ruptured membranes, maternal status for group B streptococcus. Did she receive intrapartum prophylaxis? Was it just narrow like penicillin or broad spectrum? And the timing of antibiotics prior to birth. And those risk factors are combined with the clinical signs, and the risk of sepsis is then calculated. And the use of the sepsis calculator has been used now throughout the world and has had a great effect on the risk of empirical antibiotic therapy. It's just a meta-analysis showing that the use of empiric therapy decreased markedly with use of the sepsis calculator. But here are some limitations of the sepsis calculator. It misses a substantial proportion of babies with early onset sepsis, up to 40%. So it's not going to pick out every baby with sepsis. And we still recommend treatment of over 200 babies for each case of confirmed sepsis. The sepsis calculator will not identify some women with proven intra-amniotic infection. And the sepsis calculator has three categories: well-appearing, equivocal presentation, and clinically ill. And the equivocal presentation overlaps with babies undergoing the physiological transition to postnatal life. And then there's seroobservation. In seroobservation, you keep coming back and examining the baby, relies on clinical signs of illness to identify babies with early onset sepsis. Using this approach, regardless of any risk factor, infants who appear ill at birth or those who develop signs of illness up to 48 hours are either treated or evaluated by laboratory testing. The problem is there's pretty limited data for seroobservation. If you work in a hospital and you want to use that, you have to develop a system to do the observations and document the findings. It probably adds to the cost of well newborn care. And who will do the assessments and in what setting will the serial assessments take place? Ideally, they would take place in the room where the baby is rooming with the mother. And if you look at the seroobservation, we do see use of ampicillin. The upper curve shows how ampicillin use is reduced by seroobservation, and fewer babies had CRP determinations in the first 3 days of life. So the infants require 5 to 7 days of antibiotics, even when the blood culture is negative. You have to ask yourself, where did 5 to 7 days come from? It came from this gentleman on the right, Emperor Constantine the Great. He defined the week as 5 to 7 days. And a week was considered a Constantine unit. So it made sense. People said, let's treat for 7 days. Had he chosen 4 days, I think we'd be using a lot less antibiotics in 2023. The duration of antibiotic therapy is still very prolonged in North America. These are data from the Canadian Neonatal Network, looking at VLBW babies, showing that 41% of those babies receive 4 to 7 days of antibiotic. And this is a database of over 40,000 babies in the United States. On the x-axis is days of antibiotic therapy. So sure, some babies get only 2 or 3 days, but you can see lots and lots of babies in this database receive prolonged antibiotic therapy. Are we getting better? Yes. Well, you can see the number of babies treated for more than 3 days, more than 4 days, more than 5 days is going down, but it's not good enough. And finally, how long should well-appearing late preterm and term babies be observed before discharge? These are data from Bill Bennett's, and it's looking at babies who were evaluated with the sepsis calculator. And the sepsis calculator has 3 categories. The light blue is the risk of sepsis less than 1 per 1,000. The orange is 1 to 2 per 1,000. And the dark blue is greater than 3 per 1,000. So most babies who had the sepsis calculator risk of sepsis greater than 3 per 1,000 presented in the first 12 hours of life. But those with a lower estimated risk of infection, 1 to 2 per 1,000 or less than 1 per 1,000, some of those babies presented up through 72 hours of life. So just because a baby is well here does not mean you can take a deep breath and not follow those babies. And we would recommend that at least 48 hours of observation be used if you're not going to treat a baby with antibiotics. And finally, I think this is my last slide. So babies with signs of sepsis should receive empirical antibiotics. If they are critically ill, the antibiotics should be continued. Antibiotics should be rapidly discontinued. For me, that means 36 hours if the blood culture is negative and the infant is improving. Asymptomatic late preterm infants and term infants with risk factors for sepsis, including intra-amniotic infection, can simply be observed without cultures or empiric therapy. Preterm babies at very low risk of infection, delivered from maternal indications without ruptured membranes, can be managed without antibiotics. So there it is. Thank you very much. And I would be delighted to answer any questions.
Thank you, Rita. That was a fantastic overview about how we think and talk about sepsis every day. We talk about it every day as clinicians, and we try to make decisions. And I particularly appreciated that last bit where you showed over time, we as clinicians have changed, but only a little bit, and even though we're not using the same arguments, it's hard to change, I think. I think you highlighted the dark side of antibiotics pretty well. Some of the things which we know, but is becoming now more and more science-driven and sent to us as a consideration why we sometimes shouldn't give antibiotics. And I like your definition of antibiotic stewardship, the right antibiotics at the right baby at the right time and in the right dose, not just not giving antibiotics, but a much broader concept. There's a couple of questions. I'll start with the first question in the box, and we'll lead on from there. So Dr. Rao was asked about, there's some controversy about a universal screening for GBS versus risk-based screening. What's going on in that world, which is of course related to prevention of early onset sepsis?
So thanks for the question. A number of years ago, the risk-based strategy and universal screening were both in practice, but a number of studies at that time showing that the risk factor-based strategy was not as effective as universal screening for group B streptococcus. And in our country, I think everybody, all women, receive a antenatal culture somewhere about 35 or 36 weeks gestation. So we use a universal screening approach. The risk factor-based approach is not as effective.
Thank you. I'll wait for some more questions to pop up. I have a question on more of a towards the nano trial, because, you know, we've been treating antibiotics, like you said, 90% of every small baby has been treated with antibiotics at some time, but I think we can count the randomized trials using antibiotics versus placebo on one hand, and maybe two. This nano trial, how did it go? And is it difficult?
The answer is yes, it's difficult because we have to get permission from the mother to randomize the babies, and women hear the thought of no antibiotics and immediately say, how can you not do that? So in the nano trial, we've excluded babies at lowest risk of infection, those delivered by elective cesarean section, and we will not enroll a baby where there's intra-amniotic infection. So everything in between, prolonged ruptured membranes, PPROM, inadequate treatment for group B streptococcus, all of those babies are being enrolled in the trial. But we are extending it to international sites. Hopefully Singapore is going to come on as an international site. But it's been a study that's been difficult to do because parents are reluctant for us not to give antibiotics.
It's our experience as well, even in the NICU, because maybe that's my follow-up question. How do you think we can progress into antibiotic stewardship in the NICU? Is that should it be randomized trials or should it be something different?
Well, I hope this randomized trial will show we're looking at microbiome plus the composite the composite outcome of late onset sepsis and mortality and necrotizing enterocolitis. I think this randomized trial may help, but I think people have to ask themselves, in any given baby, what is the likelihood that what we're seeing truly represents sepsis? Is it a preterm baby who's just sick, that was born from maternal indications? Well, that baby has an extremely low likelihood of sepsis. Or is it a healthy appearing term or late preterm baby whose mother's had intra-amniotic infection? Again, that's a very low risk group, 1 in 25,000 for sepsis. So I think as a start, we have to pick out the low risk groups and try not to give antibiotics when a baby meets those criteria. But on the other hand, we believe our blood cultures. So if a baby is admitted to the NICU and start on antibiotics, and if the blood culture is negative, we try to stop antibiotics and not rely upon ancillary laboratory studies.
Thank you. Tim Cochrane has a question which is related to the sepsis calculator. Well, they're using it in their center. I think many centers are using it now. And the threshold for antibiotics is that over 3 in 1,000. But he says, therefore, are we treating 997 babies to catch 3 with a true sepsis? And is this threshold appropriate?
Well, it was a committee-based opinion. It is not based on hard data. They decided in deciding what to do for the various thresholds, less than 1, 2 per thousand, or 3 per thousand, to use that 3 per thousand as the indication for antibiotics. But again, I mentioned that you're treating over 200 babies to identify the one baby who actually has proven sepsis. So it was based on expert opinion, but not based on evidence.
Thank you. So just to get a little bit further into that sepsis calculator, because you mentioned, we probably can't have one for the lower gestational age babies. How should we move forward there? Also with just selecting the low risk babies?
I think you have to identify what are the risk factors as the baby can sit. I think the Committee of Fetus and Newborn approach is correct. Identify the baby as low risk or higher risk. Sometimes it's not so clear, but in a lot of babies it is, and not rely upon clinical signs to say baby is sick or not sick. But again, in the low risk population, trying not to give antibiotics, merely provide supportive care.
There's another question here from Srini Bolasetti from Sydney, which, let me go to this. Nowadays, in a culture, plates are kept continuously monitor culture growth, and an alarm goes off if something grows. But previously, the wait for 36 hours is no longer required. Have you explained that correctly, Srini? I'm not so sure. But that's why they have a change in their center where neonatologists now move to stop antibiotics at 24 hours, because knowing that the dose given at 24 hours will still cover the next 12 hours. Do you think, is that possible? Can we move to 24 hours?
Absolutely. In fact, I think that we're moving away from standard microbiology to PCR-based diagnosis. In fact, whenever we take a blood culture, it's analyzed now using PCR and standard microbiologic methods. And 24 hours may turn out to be too long, but some centers are now stopping antibiotic therapy at 24 hours. We have not done that yet, but there's a pretty good rationale for doing that.
Yeah. So about that PCR, that's measuring components of the bacteria. And you also mentioned this transitional neonatal bacteremia. Would that impact each other?
Yeah, it's hard to tell babies who have transient, you positive blood culture. If the baby looks well and you take a repeat blood culture and it's negative, that's the definition of transient neonatal bacteremia. But I've seen lots of babies who have that. It is more common than we think. But at the moment you get a positive blood culture, you have to make a decision. Baby looks well, and you say to yourself, well, maybe this is just transient bacteremia, or baby looks sick, and this baby needs antibiotics.
So, and one more question, which is, and I think you already sort of said that from your opinion, but maybe you want to highlight a bit more. If there is a negative blood culture and a baby's getting better, you will stop antibiotics irrespective of CRP and procalcitonin.
That is absolutely correct. I used to love C-reactive protein. If you look at my lectures from 10 years ago, I talked about CRPs and sensitivity and positive and negative predictive accuracy. By the time C-reactive protein or procalcitonin can be used as significant, most of the time the blood culture is already back by that point. So I do not use those kinds of ancillary laboratory tests to help me make the diagnosis whether to continue antibiotics or not.
Yeah. So the focus should be on taking a good blood culture You highlighted that the 1 mil is sort of a minimum. Did blood culture technology advance? I think is the technology better now than it was in 1991? And can we use less, or is that still not the case?
I think technology is much better than it was 20 years ago. But I think if you have very low colony count bacteremia and you're using standard microbiologic techniques, then an ml ought to be the goal. Remember, it's okay if you have an umbilical arterial catheter in to draw the blood through the umbilical arterial catheter without doing a peripheral venous puncture.
All right, I think it's past 2. And there's no further questions. Professor Polin, thank you so much for spending the evening and talking to us about this really important topic. And we hope more to come about the changes which we see happening in safely reducing antibiotics exposure in newborns. Thank you so much.
I am delighted to join you.
Good night, Richard. Thank you.
All right, Julie, see you soon.
All right,
Thank you.
you're on. Okay, bye. Bye,
Bye.
everyone.